Welcome back to the Deep Dive. Today we're plunging into a topic that's really central to medicine, to pain, and honestly some pretty complex societal stuff too. Opioid analgesics. We've
Absolutely.
got some detailed lecture notes here, sort of a scientific breakdown of these, well, incredibly powerful drugs.
Mm.
And our mission for this deep dive, basically to cut through all that dense info, give you a really clear picture of what these drugs are, how they work, their effects, their uses, and maybe the trickiest part, that whole tightrope walk with tolerance and dependence.
Yeah.
Think of it like your shortcut to getting a solid grip on the science behind why opioids are, both indispensable and also potentially really dangerous.
It's a topic that really throws a spotlight on that intricate dance between the brain, the body, and chemistry. Like you said, it's about managing pain, definitely, but it's also a deep look into the delicate balance needed when you introduce substances that have such profound effects on our basic systems.
Right.
We'll really unpack the science, but in doing that, we'll naturally hit on those critical real-world implications.
Okay, let's ground ourselves first. What exactly are we trying to fight here? The material starts with pain itself, defines it as an unpleasant sensory and emotional experience, tied to tissue damage, actual or potential.
And it stresses it's subjective, right? Your pain is your pain.
Exactly. And then we have analgesic drugs, the tools meant to lessen or ideally remove that pain sensation.
And a key principle right off the bat is this idea of the analgesic ladder. It's simple but vital. Use the least potent drug you need to get the pain under control. Start low, go slow, only go up if necessary.
Makes sense. Okay, so how does the body actually feel that unpleasant experience? How does pain get from, say, your toe to your brain? The notes lay out a three-step thing. Starts out in the periphery with these special pain receptors. No step.
Gas receptors, yeah. Damage activates them, like stepping on that infamous Lego.
Right. Ouch. Okay, so that signal then travels from the nociceptors up to the spinal cord, specifically the dorsal horn.
Correct. That's a crucial relay point. And importantly, it's a place where those pain signals can be modulated, turned up or down.
Modulated. And this is where it gets really interesting. With the gate control mechanism, the notes talk about pathways coming down from the brain, inhibitory tracks.
Exactly. Descending inhibitory traps. They can basically hit the brakes on pain signals trying to pass through that spinal cord gate.
Okay.
And here's the kicker. These natural brake systems in our body, they're activated by our own opioids, endogenous opioids, we call them.
Ah, so our body already makes opioid-like stuff.
Precisely. Our brain has its own built-in pain management system using these chemicals. And understanding that is key because external opioids, they're essentially tapping into and, amplifying that existing system.
Wow, okay. So step 3, if the signal gets past that spinal gate or gets modulated there, it just travels up to the brain, spinal thalamic tract.
That's the one. Up to the brain where it's finally processed and perceived as pain.
So knowing our body has its own opioid system, that brings us right to opioid analgesics. The notes call them the gold standard for moderate to severe pain.
Yep, the heavy hitters.
And how do they work? Mechanism of action, they're agonists, meaning they turn on specific sites, opioid receptors.
That's it. They bind to and activate these specific opioid receptors. And the material points out three main types. Mu, which is written mu, delta, and kappa.
Okay, mu, delta, kappa, let's unpack that a bit, is one of those more important than the others, especially for the effects we think of with strong opioids.
Definitely. The mu receptors, those mu ones, are responsible for most of the really strong pain relief that makes opioids so effective.
Got it.
But, and this is the crucial, but they're also the main drivers behind the major bad side effects, especially that dangerous respiratory depression. Kappa receptors chip in with analgesia too, particularly at the spinal cord level. And delta receptors are also involved in the whole pain picture.
So when an opioid drug like morphine hits a mu receptor, what's actually happening at the nerve cell level to stop the pain signal?
The main thing is inhibition. It damps down the nerve cell's activity. So on the cell sending the signal, the presynaptic one activating the opioid receptor cuts down the release of pain chemicals like substance P and glutamate, mostly by reducing the calcium that needs to flow in for that release to happen. Then on the cell receiving the signal, the postsynaptic one, the opioid activation, makes it less likely to fire off its own signal. It does this by increasing potassium flowing out.
Okay.
That makes the cell membrane more negative inside, hyperpolarized we call it, which just makes it harder for the next pain signal to set it off.
Ah, so it's hitting it from both sides. Less signal sent, and the receiver is less sensitive.
Exactly, a double whammy. And the net result, Pain transmission is blocked, or at least seriously diminished. That explains why they're so powerful.
It really does. And because different opioids hit these receptors differently, some slam the mu receptor hard, some are weaker, some affect kappa or delta 2, we can classify them, right?
Yep. The material groups them mainly by how they act on that critical mu receptor. You've got full agonists, they activate it strongly. Then partial agonists or mixed agonist antagonists, which are a bit more complex in how they interact.
And the full mu agonists get broken down again by just sheer power, strong versus weak or moderate.
Right. And we absolutely have to mention the pure opioid antagonists here too, like naloxone, naltrexone.
The reversal agent?
Exactly. They're different. They don't cause pain relief. They block the effects of the agonist. They sit on the receptor but don't turn it on, preventing the agonists from working. Crucial for overdose and treatment.
Okay, let's name some names based on the notes. Strong mu agonists.
Yeah.
We're talking morphine, right? Meperidine, methadone, fentanyl.
Those are the big ones, yeah.
Yeah.
Then in the weak or moderate mu agonist category, you find things like codeine, oxycodone, hydrocodone, things often found in combination pills.
And the mixed ones. The notes mention pentazocine, partial mu, kappa agonist, and buprenorphine, partial mu agonist, but a kappa antagonist.
That's them. That more complicated interaction profile means their effects can be a bit different, sometimes with a ceiling effect on things like respiratory depression, which can be useful.
Interesting. Okay, so looking beyond just pain relief,
Mm-hmm.
the overall effects of opioids are really widespread, aren't they? The list in the notes is long. It hints that these receptors must be all over the body, not just in pain pathways.
That's exactly right. They're in the brain, the gut, elsewhere, which explains the range of effects.
In the central nervous system, obviously analgesia is the goal,
Mm.
but then there's euphoria, that intense well-being feeling, which is, well, a double-edged sword.
Hugely so, yeah.
Also, stopping coughs, sedation, meiosis, the pinpoint pupils.
Yep, that's a classic sign. And critically, in the CNS effects, that's where tolerance and dependence really take root.
Okay, moving down, gastrointestinal tract, constipation seems almost universal.
Pretty much guaranteed with regular use, unfortunately. They also tighten sphincters, like the biliary one, which can cause issues, and they often trigger nausea and vomiting, especially initially.
And other effects, vasodilation, lower blood pressure, flushing, itching, maybe from histamine,
That's often the mechanism, yeah, histamine release.
prolonging labor,
Huh.
except for meperidine, interestingly, and even urine retention.
Wow. So one drug for pain affects breathing, gut, eyes, blood pressure.
It really underscores how fundamental this opioid system is in regulating various body functions.
And this range of effects leads to their uses, right? Number one is still analgesia for severe pain, the gold standard.
Absolutely.
Also used in anesthesia, sort of as a helper drug.
As an adjunct, yeah.
Yeah.
Helps reduce the need for other anesthetics.
And codeine specifically called out for coughs, antitussive.
Correct. Still used for that.
And some opioids that don't get into the brain as much, like loperamide, used for diarrhea because of that gut-slowing effect.
Precisely. Loperamide, diphenoxylate, they harness that GI effect. And coming back to the brain, that euphoria. Sadly, a major reason for dependence, the notes say.
It's a huge factor, which leads us right into the adverse effects and what happens in opioid intoxication. Lots of side effects are just annoying, but one is acutely dangerous: respiratory depression.
Notes really hammer this point home, the
Right.
cause of death and overdoses.
Yeah.
The mechanism is they make the brainstem less sensitive to CO2, so you don't get the signal to breathe.
Essentially, yes. It blunts that hypercapnic drive, the reflex to breathe harder when CO2 builds up in your blood.
And that connects to why you shouldn't use opioids if someone have a closed head injury.
Right, because if you slow breathing, CO2 builds up, which makes blood vessels in the brain dilate. That increases pressure inside the skull, intracranial pressure, which is really dangerous if there's already swelling or bleeding from an injury.
Got it. Nausea and vomiting. Very common. Direct hit on the brain's nausea center.
Yeah.
Chemoreceptor trigger zone.
That's the spot, yeah. Direct stimulation.
And the meiosis, the pinpoint pupils, also a direct effect.
Direct stimulation of a specific nucleus in the brainstem, yes.
Constipation, we mentioned it, happens because they increase muscle tone and slow things down in the gut.
Increased tone, decreased peristalsis of the waves that move things along, slows the whole system.
And that increased biliary sphincter tone. If someone has gallbladder issues, opioids could make an attack worse.
Exactly. It can trap bile and increase pressure, causing more pain.
Other things, itching, flushing, maybe even bronchospasm, related to that histamine release again.
Often, yes. And then looming large over all of this, the really big adverse effects. tolerance and dependence.
Okay, so because respiratory depression is the immediate life threat, acute opioid intoxication overdose needs super rapid treatment.
Time is absolutely critical.
And the main tool for that, the notes say, is naloxone.
Right, Narcan is a common brand name people might know.
It's a pure competitive antagonist. What does that mean again?
Competitive means it competes with the opioid for the same receptor site. Antagonist means it binds to the receptor but doesn't activate it, just blocks it,
So it kicks the opioid off the receptor.
or prevents it from binding in the first place. It basically just occupies the receptor, displacing the agonist and reversing its effects, especially that dangerous respiratory depression. And it works fast, often within minutes.
Amazing. Okay, so that's acute. Now let's shift gears to chronic use. This is where tolerance and dependence really come into play, leading to opioid use disorder, OUD.
Right. This is where things get, well, really complex and concerning.
Tolerance? The definition is needing more and more drug to get the same effect you got at first. The body adapts.
That's the gist of it. And the main mechanism, the notes say, is pharmacodynamic tolerance, meaning the nerve cells themselves, the ones with the receptors, are changing their response.
Wow.
A key way is downregulation of those more receptors. The cell literally pulls some receptors off its surface and takes them inside, so there are fewer targets for the opioid to hit.
Wow.
And the notes also mention cross-tolerance. If you become tolerant to, say, morphine, you'll likely have some tolerance to fentanyl or oxycodone, too.
That's important. And didn't the note say tolerance develops to most effects, but not all?
Correct. You develop tolerance to the pain relief, the euphoria, the sedation, even the respiratory depression to some extent. But typically not to the meiosis, the pinpoint pupils, or the constipation. Those tend to persist.
Okay, but wait. If you develop tolerance to respiratory depression, why is overdose still so dangerous for long-term users?
That's a crucial point. Tolerance raises the dose needed to cause respiratory depression for that individual, but it doesn't eliminate the risk. A high enough dose, especially of something potent like fentanyl, can still overwhelm the system and cause respiratory arrest, even in someone highly tolerant. The ceiling is raised, but it's still there.
Got it. So tolerance is needing more drug for the effect. Physical dependence is different, though related.
It's distinct, yeah. Physical dependence is a physiological state where the body has adapted so much to the drug being there all the time that it now needs the drug just to function somewhat normally. The neurons have changed their baseline.
And if you stop the drug suddenly, or give naloxone,
Then you get the opioid withdrawal syndrome. You've disrupted that adapted state, and the nervous system basically rebounds into overdrive, becomes hyperexcitable.
and the symptoms sound awful.
Yeah.
Often the opposite of the drug's effects. Irritability, aggression sometimes, fever, sweating, fast heart rate, nausea, vomiting.
All common. And remember, meiosis with intoxication.
Pinpoint pupils.
Withdrawal often causes the opposite. Dilated pupils, mydriasis, plus goosebumps, piloerection cramps, diarrhea. It's intensely unpleasant.
But the notes stress it's usually not life-threatening, unlike overdoses.
Generally, no. Extremely uncomfortable, miserable, but not typically fatal on its own, unlike severe withdrawal from alcohol or barbiturates, for example.
Okay. And then there's psychological dependence. How is that different from physical?
Psychological dependence is more about the compulsion to use the drug for its mental effects, the high, the escape, feeling good, rather than just using it to avoid feeling physically sick from withdrawal. It's the craving, the obsession, the loss of control over use that's often the harder part to treat long term.
Understanding those layers, tolerance, physical dependence, psychological dependence, seems absolutely key to grasping OUD.
It really is.
So, how is it treated? The goals listed are pretty clear. Reduce withdrawal symptoms, cut down cravings, and help people stay off non-prescribed opioids. Maintain abstinence.
Right. And the notes break treatment into two main phases. First is medically supervised withdrawal, or detox.
Right.
The goal here isn't to cure, but to manage those rough withdrawal symptoms safely with medication, make it more tolerable.
What meds do they use for that? The notes mention longer-acting opioids, methadone, buprenorphine.
Exactly. They provide a smoother, more stable opioid effect to ease the body off the shorter-acting drug. Also, drugs like clonidine, an alpha-2 adrenergic agonist, can help calm down some of that autonomic hyperactivity, the sweating, anxiety, racing heart.
Okay, so that's phase 1, detox. Phase 2 is opioid replacement, maintenance, or substitution therapy.
Right. This is longer term. The idea is to replace the illicit or misused opioid with a prescribed one that's longer acting, causes less euphoria when taken as directed, and is generally safer and less disruptive to life. It helps stabilize people, reduce cravings, and lower the risks associated with illicit use.
And the drugs here, methadone and buprenorphine again.
Yes, they're mainstays for maintenance too. Taken orally, often under supervision, they prevent withdrawal and reduce cravings without providing the intense high. Naltrexone, the antagonist, is also used for maintenance.
But there was a catch with naltrexone.
Yeah, because it blocks all opioid effects, you absolutely have to be fully detoxed before starting it. If you take naltrexone while you still have opioids in your system, it can trigger sudden, severe withdrawal. So detox first, then naltrexone to help prevent relapse.
Makes sense. And they use other meds too, just for symptoms, like clonidine for anxiety, maybe benzodiazepines sometimes, antidiarrheals, anti-nausea meds, painkillers like NSAIDs.
Yep, those are adjuncts used as needed to manage specific lingering symptoms during treatment.
Okay, before we wrap, the notes had some quick highlights on specific opioids, kind of unique features that illustrate some of this stuff.
Yeah, those were good examples.
Morphine, the standard,
Yeah.
has that significant first-pass metabolism, meaning oral doses need to be higher, and an active metabolite that's even more potent.
Morphine 6-glucuronide, yeah, it contributes a lot to morphine's effects, especially with long-term use or kidney issues. Used for really severe pain trauma, heart attack, cancer, even fluid in the lungs, pulmonary edema.
Damn morphine.
Yeah.
It's heroin, right?
Yeah.
Twice as potent as morphine, most abused illicit.
And the key reason highlighted for its high addiction potential, it crosses into the brain super fast after injection, causing that intense rush that's highly reinforced.
Fentanyl, most potent one available.
Yeah.
Comes in a patch for chronic pain. Durgesic,
Extremely potent, yeah. The patch allows slow, steady delivery for people with severe, constant pain.
pethidine, or meperidine. About as strong as morphine, but different. Doesn't cause constipation or biliary pressure. So used in pancreatitis.
Correct. And crucially, it doesn't slow down labor, so it's used during childbirth. It also has an effect like atropine, speeds up the heart rate, which can be useful in certain types of heart attacks.
But big, but only short courses allowed.
Yeah.
Toxic metabolite risk causing seizures, especially with kidney problems.
Normeperidine, yeah, that's the major limitation. Accumulates and can cause CNS toxicity.
Methadone. Longer duration, milder withdrawal. Used specifically for treating dependence, often orally.
That's its main niche now, yeah.
Yeah.
Maintenance therapy.
Codeine, much weaker, like 112th of morphine. Mild, moderate pain, often combined with Tylenol or something.
Right. Also used as a cough suppressant. Paradoxically, quite constipating despite being weak. Less addictive potential than morphine, but...
But its effect varies a lot between people because it needs an enzyme, CYP-DD6, to turn into morphine in the body.
Yeah.
And people have different enzyme levels.
Exactly. Some people get little effect, some get a lot. Genetic variability plays a big role.
And tramadol, dual action, weak mu agonist. Plus, it affects serotonin and norepinephrine reuptake. Good for nerve pain.
That dual mechanism makes it usable for certain pain types, yeah. Main side effect to watch for is seizures, though it's relatively rare at normal doses.
Wow, that tour really shows the variety within the class. Okay, the note's finished with a couple of quick check-yourself type questions. Let's try them. First, if someone has pinpoint pupils and their breathing is really slow, what's likely going on in terms of opioids and receptors?
Based on everything we've said, that screams classic opioid intoxication, almost certainly mediated by strong activation of the mu receptors by an agonist like morphine, heroin, or fentanyl. Respiratory depression and meiosis are hallmark mu effects.
Right, hitting those mu receptors hard. Okay, second, someone's unresponsive, maybe signs of drug use, paramedics given naloxone. What's the naloxone doing?
It's acting as that pure competitive antagonist. It gets to the opioid receptors, especially mu, bumps the agonist opioid off or blocks it from binding, and reverses the effects most critically. It reverses the respiratory depression, allowing them to breathe again.
That competitive antagonism. Key antidote action.
Right.
Okay, so pulling it all together, we've done this deep dive into the science.
Yeah, we've gone from how pain signals travel to how opioids hijack our own internal system via these receptors, looked at all their effects, good and bad, and really dug into tolerance and dependence, which is so crucial.
Right.
And seeing the specifics of different drugs like meperidine's quirks or codeine's metabolism, it paints a picture of powerful tools, definitely, but tools that come with huge complexities and serious risks.
Understanding the science behind, like, receptor downregulation for tolerance or that rebound hyperexcitability and withdrawal, and separating physical from psychological dependence, it really clarifies the challenge of opioid use disorder, doesn't it?
Absolutely. And seeing the treatment strategies, the detox, the maintenance with drugs like methadone or buprenorphine, it shows it's a complex approach, hitting both the physical side and trying to manage the psychological drive.
This journey through the science gives a solid base, but the source material actually left off with a really provocative question, something for you, the listener, to think about. Would not Earth look much better without opioids?
Wow. Yeah, that's a heavy one.
It really captures that tension, doesn't it? You have their vital role in easing terrible suffering.
Mm.
And then you have the devastation of addiction, overdose, of the whole opioid crisis we hear so much about. What hits you most when you consider that question after this dive?
For me, it really highlights the fundamental trade-offs we constantly face in medicine. We develop these incredibly powerful tools to relieve suffering, but that power often comes hand in hand with the potential for serious harm, especially when it interacts with our complex biology and, human behavior. There are rarely easy answers.
No, there really aren't. It's a complicated world. Well, thanks for joining us for this deep dive. We really hope you feel better informed, maybe have some new perspectives, and feel ready to think critically about this incredibly important and, yeah, challenging topic.